Yes, you are audible.
Okay, thank you, sir. So let me go through the corporate presentation of Integris MedTech. So Integris MedTech is India's leading diversified MedTech platform for global emerging markets. If we see, we have two arms as of now. We have Everlife, which is a leading lab and analytical equipment platforms in Southeast Asia, and we have Translumina, which is a leading cardiovascular solution provider in emerging Asia and Europe market. If I will talk about what is Integris MedTech, an overview, it have diversified portfolio in cardiovascular, in vitro diagnostic, and in scientific lab solutions. It is number one player in scientific lab solutions in Southeast Asia. Uh, as you already know, uh, Translumina, which is second largest stent player in India with around 18% market share all over India. If I talk about overall Integris and Translumina, we have around unparalleled market access with around 2000 plus hospitals and cath labs directly covered and around 17,000 plus laboratories directly covered. If I will take a deep dive with Translumina, which is the interventional cardiology business of Integris MedTech, we we are a leading cardiovascular device company with second largest stent player and a second largest stent player in domestic market with 18% stent volume share. We also have a large global presence and strong clinical pedigree with 10 plus years of clinical data and robust manufacturing plants. We have around five manufacturing plants across India, Germany, and Netherlands. Also, we have an extensive network coverage of more than 2000 plus physicians, 1000 plus cath labs, and 120 plus distributors all over India. If I talk about the overall product portfolio of Translumina, we have four divisions, starting from accessing the lesion to assessing the lesion, then preparing and treating the lesion with products like Asahi, Kanika, Assist. Now we have CVI, contrast delivery system. Then for assessing the lesion, we have Assist Kodama catheter. For preparing the lesion, we have Shockwave, OPN, Cis Medical. We have Optima balloons. And then for treating the lesions, as you already know, we recently partnered with Medinol also. And we have Elunir Pearl, our Vivo ISAR, and our in-house manufacturing stents. So this is all about Translumina. Now I will urge Dr. Dannenberg. I will urge Dr. Srinivasan first to introduce everyone, and then we can start with Dr. Dannenberg's presentation.
Yeah, thank you. Good evening, everybody. So this evening, we are going to share our knowledge and experience about the Ridoforol stent, and as the manufacturer claims, it's a very unique stent as we see because the drug is also unique. It's not a pro drug as they say, and they say that it has got an elastomeric coating which prevents cracking, peeling of the coating, unlike other stents, and they have a specific cell design, the so-called YZ cell design, and which gives a uniform drug delivery, and they have a flexible hybrid metal spring tip which is enabling the flexibility and deliverability of the stent. And another important thing is they have radio opaque markers on stent, so which makes this stent very unique. And to discuss on this, we have Dr. V.S. Prakash, Manipal Hospital from Bangalore, and Dr. Dilip Kumar, Medica Hospital from Kolkata as chairpersons. And we have expert panelists, Dr. Keshav Kale, Medicover Hospital, Navy Mumbai, and Dr. Ravindra Guli, Fortis Hospital, Mumbai. And we have three speakers from India and one international speaker. So from India, we have Dr. Sunil, Manipal Hospital, Bangalore, and Dr. Hansora from Sanjeevani Hospital, Gujarat, and Dr. David Varghese from Kerala to share their real-world PC experiences with this unique stent. And coming to our international speaker, Dr. Hallam Danberg. Good evening, sir. And he is from Olsen Medical Center, Israel. And when I was given his CV, it was like a book actually. It took 1 hour to go through all those things, such a big volume of CV. I read through that. So I have summarized to introduce him to you all. So he has graduated his medicine from Hadassah Hebrew University Medical School, Jerusalem in 1985, and then had his postdoctoral fellowship in vascular biology from Cambridge, America. And he has enormous academic as well as research experience and has been a proctor for TAVI to companies like Medtronic, Abbott. And presently, he is holding the position of Director, Interventional Cardiology at Olsen Medical Center at Israel. He has been an active participant in many scientific meetings across the world, including India Live. He has been as Director, Secretary, and Chairman various organizations. He has been a mentor for many MSc, PhD students and MD students. To his credit, he has many honors, awards, and patents. He also has more than 100 publications of original papers, editorials, case reports, review articles in more than 100 journals. So that's how his CV goes on. So I have summarized. And thank you, sir, for being with us. And we have all the legendary speakers from India. So over to the speakers now. Thank you.
Thank you very much, Dr. Srinivasan, for this wonderful introduction. I'm always happy to meet colleagues from the wonderful subcontinent from India. I was fortunate to visit many times and proctor mainly structural procedure. And I'm always fascinated by the, first of all, the knowledge, skills, and enthusiasm of the Indian interventional cardiology community. And today, I would like to share with you a unique drug-eluting stent platform, an Israeli one. This is the Elunir Pearl by Medinol. If I can share my screen with you. Can you see now the presentation?
Yeah.
You're with me here? Okay. So just a second. Somehow I missed the just a side. Sorry. Trying to bring it up. Okay. Just to say, I'm sorry. I have to.
It's visible, sir.
Yeah, it's visible.
Yeah, somehow. Oh, okay.
It's visible, actually.
I cannot see the my screen all of a sudden.
Maybe you can just unshare once and then again reshare.
I'll do an unshare and then. Sorry. Okay. Stop share, and I'll try sharing again. Better now?
It will come.
Yes, now it is visible.
Okay, let's go.
Just put it on presenter mode and you're good to go.
You're good now. Okay. If you can see me, I will continue.
Yeah, we can
Yes.
see you.
Okay. So today, with your permission, I will present some data, precision, performance, and proof with the Everolimus drug-eluting stents, or as we call it here, the Elunir Pearl. And it's indeed a wonderful stent platform that was designed with a lot of vision and excellent engineering capacity to allow good conformability, deliverability, and a very safe stent platform to use. And actually, it became our workhorse in our lab as well as in many other labs here in Israel. The stent has the markers that allow a good visibility, is a very deliverable one due to the balloon system and the metal spring tip covered by nylon jacket at its edge. And at the end, in addition to some cases, I will share with you the clinical data that support the efficacy of this wonderful system. The bare metal platform is a balloon expandable cobalt chromium stent coated with first a polymer, which is a blend of carboxyl and PBMA polymer, and the drug is a Limus, one of the Limus family. This one is the Ridaforolimus stent. So cobalt chrome, polymer, and the Ridaforolimus. And as you can see here, and a little bit of science, and we'll move on to what we enjoy more. You see here that the effect, the inhibition, is larger on smooth muscle cells, reducing neointimal growth, while the effect on endothelial cell is minimal. And this is, and you can see here the Ridaforolimus as compared to Everolimus, which, as you can see here, is more effective on endothelial cells. Sirolimus with actually quite similar effect, and Zotorolimus, which we see on the Medtronic stents, and here it's quite the same with a good therapeutic window. The stent is composed of two different struts, ultra narrow and narrow struts. The struts range between 40 micrometers and 72. And actually, the Elunir Pearl prides itself with the lowest metal footprint as compared to the Synergy, Xience, the Resolute Onyx with its 96 micrometers of struts, and the Orsiro, which is a small one, yet larger than the stents are larger than the Elunir Pearl. The stents is a very conformable one. The scaffolding, as you can see here, keeps it the sizes, even when deployed on curves, and on very curved vessels, very tortuous vessels, the cell size stays uniform. And this is, as you can see here, these are the cell sizes in other stents. They may vary in size, especially when you go in curved vessels. The Elunir Pearl keeps its uniform cell size, and this is translated. You'll see here the difference in sizes. It keeps itself in a very small manner, despite those tiny struts, and this is translated to a better drug disposition. See here the Elunir Pearl, very uniform as compared with competitor drug-eluting stents. If you keep it, the scaffolding and the cell size uniform, the drug disposition, the drug distribution will be uniform as well. No underdosing and overdosing, as you can see here in this drug disposition imaging. This is computer simulation of the drug deposition within the artery. Elunir Pearl, uniform cell, uniform drug deposition. Competitor drug-eluting stents, different cell sizes and different drug deposition, which may translate to an effect on neointimal growth. Now, a lot of thought was invested in the engineering of the stents to allow us, first of all, better deliverability. you'll be able to see when using the stent, you'll see the tip is a very low tip entry profile, which with reduced friction. The tip is covered with a nylon jacket, and therefore, despite having very good radial opacity, you do see the spring, the tip very well. It's got an excellent deliverability, excellent crossability, and this is in addition to the stent, which is, as mentioned, a low profile, with those two markers on each tip that provide us with excellent visibility. The stent, despite having very narrow, very small struts, is visible, not only the stent platform, but those additional markers at both ends that allow us very accurate positioning of the stent. And I'll show you some example. It became not only that it's our workhorse, but definitely our default when using treating bifurcation, left main lesions, in which we're trying to be very accurate in our positioning. So, a hybrid spring tip for superior deliverability, and you can see here comparison with the tips of the metal-informed spring tip of the Elomir Pearl as compared to Xience, Synergy, or Resolute, that are causing, when you're going in a very steep, tortuous artery, the tip may create a fish mouth that increases friction and hampers or make crossability hard. Here, it's uniform, no fish mouth, and excellent crossability. And I mentioned earlier the tips. You can see here the markers. So you can see here the stent is visible. I don't know if my screen allows you a decent visibility of the stent. So I'll share with you some other examples in a minute. Here, under a high mag, you can see how the markers look like. And it's not only one marker at each side, but two that would allow you excellent visibility from any projection that you're taking. And you know exactly where your stent is deployed, whether it's before a branch, after a branch. Very useful in clinical practice. Now, it's not only good engineering, but it all starts with the production, the manufacturing, and what Medinol, which is a large Israeli company, not far from here in Jerusalem, where the factory is, what the company prides itself is the very advanced manufacturing capacity. The stent is cut out of a stent panel by laser, automated visual inspection of the stent panels. It's all very, very efficient process. And the coating is an elastomeric one, the only technology that enables a uniform elastomeric coating, and you'll see this in a minute. So stent cutting, all automatic. As you can see, working not on a tubular stent, but rather on a panel, on a flat panel, and only then coming up with a coating, which when you do it on a flat surface, it's definitely more uniform than what you can get when you're coating a circular or a tubular structure. So definitely much more uniform. And I guess that this is translated to better efficiency in reducing neointimal growth. And I showed you the flat coverage of the elastomer and the drug. And you can see here under electron microscopy that the polymer coating, the uniform one, is definitely beneficial in reducing surface deformity. And here you see this is the Elunir Pearl, very uniform coating. And this is in comparison to the Resolute, Science, and Synergy. And I was provided with hundreds of pictures showing exactly the same. Those cracks, deformities, webbing, peeling of the polymer on all those stents as compared to the very uniform coverage of the Elunir Pearl. And I guess that those imperfections can be associated with increased thrombogenicity, inflammation, as well as non-uniform drug release, which may be translated to enhanced intimal growth, i.e. restenosis. Here are some data from the clinical trial, and the Elunir Pearl has a lot of clinical experience and substantial scientific support for its efficacy. The Sentinel trial of Elunir Pearl was the Bionics pivotal clinical trial, which I was fortunate to take part in, a multi-center large study comparing Elunir with the Biotronik Resolute with an endpoint of a target lesion failure at 24 months. And as you can see here, the results are comparable. No difference. Low rates of TLF with both the Resolute and the Elunir. It was an all-comer study showing the safety and efficacy of both the Elunir and the Resolute. Definite or probable stent thrombosis through 2 years was even lower with the Elunir as compared to the Resolute, but we can't say much since the numbers were indeed very, very low with both stent platforms. There is some bifurcation sub-analysis showing, again, the efficacy and safety of both stents. Very good numbers for both competitors here, the Elunir and the Resolute, and very low rates of TLF with both systems. Again, in the study, and as I mentioned, it was a large study, compared the results, TLF, including MACE, TLR, etc., in diabetics as well. And again, very favorable results. No significant difference, statistical difference, maybe some trend toward better MACE in the Elunir arm, but nevertheless, we can't say much good results with both systems. There was an additional study, kind of a sub-study, the NEUROS, in which there was angiographic follow-up at 6 months, and again, excellent results, very low late lumen loss with both system, and excellent results in this study, 300 patients, 2-to-1 randomization, excellent results with the Elunir. And when you pull together the Bionics and the NEUROS trials, the Vidofludimus versus Zotarolimus, over 2,000 patients, you can see here, excellent. You'll see here TLF at 24 months, 7% with the Elunir, 7.2 with the Resolute. Quite comparable, excellent safety and efficacy for both. And you can see here again the stent thrombosis. These are the pooled data from the Bionics and NEUROS, almost reaching statistical significance, P of 0.09 for stent thrombosis at 2 years, which is lower, 6 cases with the Elunir as compared to 9 with the Resolute. Excellent results for both. The study, similar study was held in Japan as well. That's the J-NEAR, Elunir clinical trial in Japan. You know that you need a study dedicated to the Japanese population 500 patients randomized 4-1. And again, the study was led by Dr. Saito, mentor to many of us, and as you can see here, ran throughout Japan with excellent clinical data. Here, target lesion failure was compared with the Bionics trial, and as you can see, the data in Japan is even better. Excellent results, nevertheless, with the Elunir Pearl. Stent thrombosis was low. And with your permission, I would like to share with you some cases done here in our lab at the Wolfson Medical Center. Here's a young gentleman, heavy smoker, COPD, just 56-year-old gentleman admitted with acute coronary syndrome, non-STEMI, elevated troponin. And here is the, actually, I think it was the first injection. And you can see here, tight lesion at the ostial LAD, almost touching on the left main. Now, one would actually advise us to go for surgery in such a young gentleman, nevertheless, heavy smoker with severe COPD, and we chose the percutaneous approach. And as you can see here, with the markers, we can be very, very accurate. So we used an Elunir Pearl 4 millimeters. And here's the final result. You can see here the markers very accurately. Very accurately at the ostium of the LAD, not touching on at the distal left main or the ostium of the circ. Of course, we protected well the circ as well, but you can see here how accurate you can come up when you're using the Elunir Pearl with its dedicated markers for accuracy, for precision. And I think we can all agree that with this, I was quite happy with the results. Here is an older patient, 86-year-old, with all those risk factors, diabetes mellitus, renal failure, creatinine over 2, after PCI to LAD and circ a few years ago, and admitted with unstable angina. And you can see here the injection to the right with 3 different lesions. Now we had to be very frugal, very tight with contrast with this diabetic lady with its high creatinine. So spot stenting 3 Elunirs, you can see them by the markers over here. One, 2, and 3. The markers allow us to know exactly what the stents are. Good results. Total contrast delivered through the procedure was about 40 cc's. And with decent hydration, no need for a renal replacement therapy. And the patient was discharged 2 days after and feeling very well. Here is an 83-year-old patient admitted with, again, acute coronary syndrome, renal failure. Here the creatinine was 2.6. And And this was the culprit lesion. In a different projection, it was even tougher. See, direct stenting, post-dilatation without even injecting in between. And the whole procedure was completed with 21 ml of, we're very frugal in using contrast in these elderly patients. Unfortunately, no renal compromise. 71-year-old gentleman, diabetes, hypertension, extensive extensive anterior non-ST elevation, MI, non-STEMI, troponin, elevated, as you can see here. Sorry. And you can see here, long calcified lesion of the LAD. Not sure that you can get the right impression of how calcified was the lesion. You see here how long it was. Very long lesion. Pre-dilatation and one single 44 millimeter Elonier Pearl. And this is how it looks after post-dilatation. In such long lesions and highly calcified, we do pre-dilatation, post-dilatation. I think that we didn't even IVUS this patient. The result, as you can see here, was a very good one. It conforms nicely to the vessel architecture and ends up nicely, and the patient is doing, we just saw him for a 6 months follow-up, doing very, very well on aspirin and prasugrel. So the Elonier Pearl is indeed a leading stent with vision. I shared with you the wise cell design, strut, the narrow struts, and the excellent design of the cells, the elastomeric, very uniform coating, superior deliverability, and I think we can all agree that the clinical outcomes are very good, not to say outstanding. I thank you for being with me today, and I'm open for any questions. Thank you very much.
Sir, you are on mute.
So thank you, sir, for giving an elaborate and very detailed insight into the new technology. I have a doubt regarding this elastomeric coating. I doubt whether it is because of the post-expansion capacity, the difference is like, because Elonier, I believe the post-expansion capacity is much lesser when compared to stents like Megatron and other stents or Zines. So because those stents go for extensive post-expansion, do the polymeric coating get broken? And this has got a limited expansion capacity. So that is why it is, or it's really an elastomeric property. And does it really translates into clinical benefit? That's my question.
It's a very good question. Whether the elastomeric coating would stay uniform actually when we dilate or post-dilate. There is abundant data. Medinol is a very serious company, so there's a very scientific infrastructure. So even after dilatation, over dilatation, you can see, and that's the advantage of the elastomer. It is elastic, so it stays uniform, no cracking. I mean, nobody can tell you what exactly happens once it's with contact with tissue, but probably it stays the same. The elastomer is elastic, so even with oversizing, and we've been using, for post-dilatation, say of a 3.5, every once in a while we'll use a 4 millimeter balloon, non-compact. it stays uniform with the same cell sizes and the same uniformity of the elastomer, which means the same drug deposition, which is, as I showed you in this colorful figure, stays very uniform.
Yeah, but my question is not that because the post expansion capacity differs from each stent. This Elunur has got, say, for example, 2.5 goes up to maximum up to I think 3 or something like that. Not much post expansion.
So, sir, the expansion limits are as such 2.25 and 2.5 goes up to 3.25.
Okay.
2.75 and 3 goes up to 4.25, and 3.5 and 4 goes up to 5.5.
Okay, actually, then I'm misled actually
I wouldn't
because
use it for 7 millimeters. I wouldn't use it for 7 millimeters of an artery, but up to 5 millimeters, 5.5, very safe to use. And this have been first of all examined in the lab whether it contains its capacities. And I can share with you, we've done a lot of such arteries, very safe. And actually, when you want to be very accurate, you know, when you put a stent, say in an aneurysm, you want to cover an aneurysm and you want to know exactly where your edges are, where the tips are. It's always Elunir for us.
yes, I accept that the unique, though that type of unique technology, like the mostly the two things which I appreciate is that the radiopaque markers are very good actually because I used 6 stents in 5 patients so far, and it's very nice to deploy very exactly because of the markers. So you reduce the radiation exposure. Even I don't use the clear stent or stent boost, and then when we overlap the stents also we can exactly uh, overlap of, like if you want to have an overlap of 2 mm or 1 mm, and that aspect also it is very good. And second thing, the tip, because in when you compare other stents, the deliverability is good actually, that I accept.
So, sir, this is
Yes,
the
I can
expansion.
see that. Yeah, because I was misled because the data provided to me by your company is different actually. That is why I was misled actually.
Actually,
The
the recent
dilatation limit which was provided to me was not like 2.25 goes up to 3.25.
okay.
Okay.
Actually, it is basically new expansion limits of Elunir Pearl recently
Okay.
approved. So this is the finalized one.
Okay, fine. Thank you.
Yes.
So shall we go to the next speaker? If there are no more
Yes.
questions, so we'll go to Dr. Sunil from Manipal Hospital, Bangalore. I hope he's ready.
Thank you
Sunil,
very
sir.
much. And with your permission, I'm back to the lab.
Thank you, sir. Thank you. Thank you.
Wonderful being with you. Bye-bye.
Bye, sir. So over to Dr. Sunil.
Yeah, I think Mr. Kashyap has to share my slide.
Okay, sir. Wait, I am sharing new slides. I hope these are visible.
Yeah, it's visible. Only thing I have to go to the presentation mode.
Yeah. Shall I start?
Yeah, please, you can start.
Sure, sure. No, I'm just sharing my experience. This is a second stent. Actually, this is the case where I was not the primary operator. I joined in between, and the issue what we faced, which and then how I dealt with and how this stent made life slightly easier. That's I'm going to share. So next slide, please. Next. So actually, there's a lady who had come with a 68-year-old lady, diabetic ventricle MI, and double vessel disease. So underwent primary angioplasty of LAD stent. You can see that. Can you run the slides? Yeah, that's so my colleague was doing somebody and then put a wire into a diagonal and did a pre-dilatation with 2, then 2.5 NC balloon, then 2.5 apart the scoring balloon also because there was a calcium. And the vessel was very tapering. If you see that, keep on running this. So rerun this slides. Yeah, keep on running. So, and then 2.75 into 15 stent was placed. And after that, the distally it was dilated with 2.75 balloon. But I think while trying to maneuver things, the wire came out and my colleague rewired, but I think it went through the struts in the proximal part and the proximal strut because the proximal vessel is around 3.754. So then nothing was crossing. Then my other colleague, whose case he joined in, he tried the most of the time under the struts and then come into the lumen of the stent distally and then go. So no balloon was going. Then I joined in. Can you go next? So it is nothing but you just keep on rerunning this one. So it is easy. So you can see the proximally it is going under the struts and entering the lumen of the stent. So multiple wires were tried. Next, please. Next. Because the stent is 2.75 and proximal vessel is around 4. So now keep on running this. So this one you see it comes out, it goes sub strut, then goes to some other place. Not easy. The other wire is also has crossed below the struts proximally. So with little bit of maneuvering for some time, I could cross from the true lumen and then proximally I did a pot with 4 into 6 balloon. Next. And then mid part dilated with 3 and could successfully complete the case. So the for me the good part was that although the stent 2.75 into the proximal 4 size vessel and it will be very small lumen and to nail it or you can thread it, it's very difficult with a wire if you lose the wire. But the markers made my life much more easier. Any other stent I would have had a lot of trouble and probably don't know what else would have done. But with the markers on the proximal part of the stent, both sides are there, proximal distal. But then you could easily make out if you are going substrut proximally, and then you can change your direction or you can use another wire and put it. So that helped a lot in overcoming this challenge in a difficult situation. So that was the benefit I found with this stent. And of course, after some time, maybe after 2 weeks, we'll do the IVUS. And then if the stent is not expanded in the middle, which is because of calcium, then we'll use an IVL to open the stent if it is needed. So that's the plan here. Thank you very much. Any comments, please? Most welcome.
Thank you, sir. Nice demonstration. So if anybody has got some doubt, they can ask actually. Was this case was done in ISR actually?
No. It's a acute MI, anterior MI, primary angioplasty.
So the wire came out.
Calcified
Initial
vessel stent was put, and it was distally dilated also with 2.75. And I think while pulling things and all, probably ox balloon, the wire got stuck and then came out, and then tried to rewire. Then it was a problem. So
rewiring was the problem.
rewiring the problem.
Probably you have stented with Elunir. That's why
Yes.
it was easy because of the markers, radiopaque markers.
Yeah, markers, even if it is the stent is, 2.75 stent proximal into a 4 millimeter vessel, it will be so narrow. You have to just you to thread it in the center of the stent is not easy in that situation. So any other stent would have been very difficult because you don't know where you are going. But the markers were so clearly visible, it will make you'll know immediately if you pay attention that where you are going substrate, and especially you close the window and you go one magnification higher, then it's very clear. So I could do it much faster.
Having said that, I have one question that do you find any um, difference in radio opacity of the body of the stent and compared to other stents, like apart from the marker?
This is my second exposure to this stent, so I have not paid attention to that much. Um, uh, but it looks little what to call
Visible.
it, visible enough to. I didn't find any problem. I need to pay attention to what you've asked. So next time.
Okay, thank you.
Thank you very much.
So shall we move on to the next
Yeah.
speaker? Dr. Kalpesh from Sanjeevani Hospital, Gujarat.
Yes, sir. Good evening, sir.
Good
Am I
evening.
audible?
Yeah, you are
Yeah,
audible.
yeah. This is my first case. I use Ilunil stent. Can I have my presentation, please? So that was a very simple case, actually thought to be a complex, because the patient was around 74 years old gentleman, and he already had a stenting in LAD and L6, and some physician has advised for the CT calcium scoring, and CT's calcium score came to around 2000. Next slide, please. So 73 years old, hypertensive, diabetic. Previously, he has underwent the coronary stenting in LAD and L6 2022. Now is presented with ACS with unstable angina, but physician advised first calcium scoring that was very high. So we have planned to the coronary angiography. Next slide, please. So next slide. Next slide. So this is an angiographical picture. Can you play this video? Yeah. So there was a patent stent in a proximal LAD. I don't have a details which kind of stent was used, and there was a 80 to 85% lesion in mid LAD, which was very tortuous. The L6 test was patent. There was no ISR. So can you play it again? Yeah. So left side, there is a very tortuous mid LAD portion, and patient had a typical symptoms of angina, and calcium score was also high. Next slide. The RCA was around 75-80% lesion with the small vessels, and L6 was non-dominant. That was normal vessel. So we decided to put a stent in LAD. The lesion was complex tortuous. But there was a stent as well as a calcification, but we thought, okay, we can able to cross it with either semi-compliant balloon and non-compliant balloon pre-dilatation followed by stenting. Next slide. So LAD was pre-dilated with a 212 into a 2 millimeter balloon, semi-compliant balloon that was went easily, luckily, and we would able to achieve the good pre-dilatations following the 2 millimeter balloon. Then we think to use Elunil Pearl stand 2.5 24 millimeter. This was the first case and first time I was using this stand, and we able to deliver in such a complex tortuous LAD, where already LAD has stented previously 3 years back, and that was easily delivered. And there was an advantage of radio opaque marker in the proximal and distal LAD, so that will be useful to where to end, and even in post dilatation, because there was tortuous vessel. If you missed Post dilatation, that could be a under expansion. If you cross the stent edge or strut, there will be a risk of the edge dissection. So that was nicely delivered with good expansion at 11 atmosphere. Next slide. Then stent was post dilated with 2.75 12 millimeter balloon. Next slide, please. Yeah, 2.75 10 millimeter NC balloon at 18 atmosphere. The radio opaque marker was advantage where to give a proper dilatation. Then this was the final result. Very nice expansion, though overlapping segment is properly expanded. All side branches are flowing, and patients was fine. This was done 2 months back, and patient is doing very nice. The RCA was just open up with 2 millimeter SC balloon because there was very small vessels, but just we left as it is without doing stenting. Yeah, this is a RCA angiography. So it is almost diffusely disease. So we have not changed the RCA vessels. Next slide. Next slide, please. Next slide. Yeah, the satisfied result with RCA post-dilatation. So this was complex PCI because this patients already has received the stenting in LAD and LCX. So we use the angioplasty. Yeah, we have done the coronary angioplasty by using this Elunil Pearl drug-eluting stent, and it has demonstrated very nice deliverability and optimal deployment with no procedural or peri-procedural complication. We achieved a good TME3 flow without any residual or lesion or dissection, and patient was discharged with a dual antiplatelet medicine. Thank you.
Thank you, sir, for that new indication I am seeing now. Because when you have a stent already in place and you want to cross that stent with another stent, it is always difficult because of the friction between the old stent and the new stent. Probably the Elunier has got this tip technology, this spring technology that might help us to do that. It's a new indication. Okay. Thank you. Very nice. And the final result is very good, actually.
Thank you, sir.
Thank you.
Yeah.
So if there is any more discussion on this case, if anybody wants to have any clarification, hope I am audible.
Yes, you are audible.
I hope there is no more discussion on this. So we can, shall we go on, move on to the next speaker?
Yeah, hello.
Yeah,
I
sure.
hope I'm
Okay.
audible. Yeah,
Yeah.
I hope I'm audible to everyone.
Yes, you are audible.
Yeah, and I would like to have the slide sharing, please.
So this is Dr. Varghese, David Varghese from Kerala.
Yeah. Yes.
Okay, welcome, sir. Welcome. You can start your presentation.
So, yeah, could you kindly go to the first slide, please? So yeah, basically, it's basically a staged PCI of a lady. She was a next slide, please. She was a 73-year-old lady who had presented in the 9th month of last year. She had presented as a late presenting posterior wall MI, and she underwent a primary PCI to the circ. At that time, she had a lesion in the LAD, which we had planned to tackle at a later date because the primary PCI procedure was a bit stormy. She had on-table hypotension, CHB, a lot of things. So we did not actually tackle the non-culprit lesion at that setting. Her other comorbidities included diabetes and hypertension. She was fortunate to have a normal LV, so she came in as a walk-in patient for a staged PCI to LAD, and she was admitted for the same. So next slide, please. So yeah, we had initially for the primary, we had tried the radial route, but then it was very tortuous, and even the guide wire, it was not really going. So the primary we had done through the right femoral approach, and so for this, the stage piece, I also we had decided on RFA approach. So we did an RFA approach. Next slide, please. So the hardware which we used was basically a 6FXB3. And basically, when you look at the angiogram, you'll have she had a major diagonal also arising astride the lesion. So we had planned to wire both. The LAD was wired with the cyan blue, and the diagonal was through a run through. And kindly go to the angios, please. The next slide. So basically, that's the femoral approach, and then of course the angio with the major diagonal and the LAD. And as you see, it was a tortuous LED. So finally the wire was passed. And then we also wired the diagonal. And next slide, please. Basically wired both. She underwent pre-dilatation with a 2.5 balloon, and then because of we had decided to use Elinor because of two reasons. One is the tortuosity of the vessel, and second is since there's a major diagonal, I did not want to have any compromise on that. So basically, since there was enough of gap for me to cross into the diagonal, that's why we went for the Elinor. So basically, we deployed a 3.5 into 24 Elinor pearl, and as the prior presenters have mentioned, of course, the presence of a radiopaque marker is very helpful, especially in reducing, as sir has mentioned, for reducing the radiation exposure. And of course, also like we don't even need to use the clear stent or stent boost, because the balloon can be visible very clearly when you are like post dilating. So then, as is routine, we recrossed and we post dilated with a 3.5, and actually post dilated to around 22 to 24 atmospheres. So the next slide, please. So basically, that is the final result. So I was kind of happy with it. He also has a stent in the circ, which is also fine. No issues with that. So I thought the case was done with that. So because the stent tracked well, it took over the tortuosity. There was no issues to recross to the diagonal, and deployed at nominal and post dilated with 24 with adequate areas, at least angiographically. And so I was happy with that. And then thought, okay, the case is done. And then next slide, please. Then while doing the case, she was complaining of some abdominal pain. So then, since there was a catheter in situ, I did take a check shot while we were coming down. Next slide, please. So basically, that is a check shot, which basically showed a dissection in the right external iliac. And so I had two options. One was there was flow, so there was actually flow. It basically might have been a wire-induced dissection. I'm not sure. It might have closed off at a later date, but then since she was a walk-in patient, so we gave two options to the bystanders. One is we could basically wait and watch, leave the sheath in situ, wait and watch to see if there's any hematoma, HB drop, or anything. Or second, to just tackle it off at that time itself. So then they were all right with kind of tackling with that. So then we kind of put in a 18 to 60 bare metal stent across the right external iliac. Next. Please. Yeah, so basically we stented the external iliac with a 18 to 60. We shot after that. So basically that got covered, and that was all right. So then we thought, okay, walk-in patient, we dealt with. Yeah, sorry for that. The app, I think, kind of closed off in between. And then that was done. Then the patient was shifted to the cardiology ICU. And then post procedure, like maybe within 1.5 to 2 hours, she was complaining of severe chest pain, breathlessness, and hypotension. And the ECG showed like global STT changes. So like we were doubtful, was did she go for a hyperacute stent thrombosis or something, because hypotension, all that was there. So then we intubated her, ventilated and intubated her, and we took her up for an emergent CAG. And next slide, please. So that was the emergent CAG. As is seen, there was no issue with the stent per se, but there was like diffuse coronary spasm. I think only the stent area is the only one which has the actual size. All the coronaries below that is basically in spasm. But fortunately, she kind of picked up. So I think we gave her because she was given diuretics for the pulmonary edema. She was given morphine for settling her. She was basically calmed down, because whenever she gets stressed, her BP was just spiking up to 200, 220 and all that. And fortunately, over a period of 1 or 2 days, we were able to wean her off inotropes, diuretics. Next slide, please. Inotropes, basically she had a transient LFT RFT rise, and which was brought down. She was extubated and she was discharged on the 5th day. She has come for 2 or 3 follow-ups after that. So, kind of fortunate to have like all's well that ends well. So with all this, and what I think what most of the speakers have said, the trackability is good. The presence of a radiopaque marker is, of course, an added advantage for us, because we get exposed to radiation every time, so we can reduce that off. And of course, you can, and of course, for placing, it's a very good. Otherwise, we have to kind of look at where the stent threads begin. So we can just, this marker kind of helps us to place it off very clearly. So it's all in all a very good stent so far. I think I used 3 or 4 so far. This was the only case which had some complications. The others were more or less straightforward. So hopefully, maybe over a period of time, when using it more, we may understand more pros and cons of the same. And thank you for the patient listening. So any queries, feel free to ask. Thank you.
Thank you, Dr. David, for that nice presentation of showing how a simple case turned into a monster case. Now it reminds me of 2 things, that when you do this stent, will be very helpful when we do bifurcation stenting like mini crash or a nano crash. This stent markers will be very helpful actually. So that is the point which I added. I wanted to add that. Initially, when you showed this, I thought probably the digital LED has occluded, because you stented only the diagonal. Yeah, that's what I thought. Okay, thank you.
Thank you so much, sir.
So is there any discussion, or we are closing the session? I'm asking the organizer.
Yes, sir. If you have any doubts, any one of you can discuss, or we can wind up the session accordingly.
I hope we can wind up the session, because I don't think nobody has got to say anything anymore.
Okay, sure, sir. Thank you for the wonderful presentations, and we hope that Eluni Pearl helps you in advancing patient care with all of us together. So thank you, sir. Thank you everyone for joining.
Thank you everyone. Thank you. Bye. Good night.
Thank you.
Thank you. Good night.
Good night, everyone.